We get to the second part of our talk, which is it's a different vision of how suicidal thoughts are built up there in the brain, and how do patients take that decision to end their lives. So I will start because my presentation has 4 exercises. So it's very practical in the way you are dealing with suicidal patient. And I like to start with the empathic interview. Empathy simply means that I show the other that I can understand what's getting there inside him. It's not sympathetic, so that I'm not taking the same feelings, I'm not adopting the same feelings, but simply the fact that I can understand how does he suffer should reach the patient so that we are both on the same line. So this is what we call the empathic interview. And I do like this description made by Harper in '91, and it is a very, very simple 4 steps that can easily be applied simply to show someone that you are empathic with him. And this applies not to a patient in crisis, but rather if you are notified in a psychiatric liaison for a patient who has been admitted to the hospital in the emergency department because he has committed suicide, and they are notifying psychiatrists to come. And the psychiatrist, when first see the patient, or maybe a clinical psychologist, but in Egypt we have clinical psychologists are very, very, very scarce. So almost psychiatrists are doing the job. So what to do the first visit you encounter the patient? Well, it's simply those 4 steps as follows. Well, try to use the patient's words. Try to rephrase what the patient says. Focus on emotions. And don't tackle any cognitive or rational issues. I mean, I'm not making a moral judgment. I'm not saying whether what he did is right or wrong. I'm simply assuring the patient that I can understand how does he feel. For instance, a patient come and say, well, you will introduce yourself first, and then, oh, I know that I have been notified by the emergency because of your suicidal attempt, and I know that it's a very difficult decision. Can we talk a little bit about how you came just to take that very difficult decision? If he is trying to explain the problematic issue that provoked his ideas about suicide, we are not going to discuss this issue with him. Simply I will say, yeah, I can understand how terrible you feel, and if anyone at your place may feel the same feelings. Can you explain more? How did you feel that, and what ideas came in mind, and how did you feel at that moment? So you are making a more and more focus on the emotions. All right? And every now and then you will take, so as I could understand, you said that, and try to rephrase what the patient says once and once again, and always use the same words the patient is using. So it's a very easy technique. So it is used, as we said, not in the crisis, but if you are notified to see a patient who has not succeeded to commit suicide, but he already attempted. I think I will skip the exercise, and maybe if we have time, we can make it after. But I will take the CBT model, which is the cognitive behavioral therapeutic approach. And the DBT, the dialectical behavioral approach, is a little bit different from the classical CBT in 2 things. Firstly, it validates more what the patient says, rather than being very instructive like the CBT. The patient is thinking badly or wrongly, and I'm going to inform him how he should think, so that his thinking be appropriate and not a faulty thinking. And the second difference is the frame. In the DBT model, the patient has a lot of psychological interventions around. I mean, each patient has a phone coach, he has a weekly individual session, has a group session for skills and emotion regulation on a regular basis every week. So the patient has a lot of interventions around. But in classical CBT, it doesn't go like that. You can receive the patient once every week, maybe twice weekly, but not shorter than that. Because simply if you are going to give assignments to the patient should have enough time to do those assignments. So the CBT model is based on this ABC model that's very famous, that has been created by Albert Ellis. And the A stands for a lot of meanings. Albert Ellis called it activating event. Some authors call it awareness. Beck called it automatic thoughts. There are some difference. And Maximus B. Jr. called it attitude, and so on. So anyhow, there is any event or a situation or a person I was in a certain experience with, and then I had a certain beliefs or certain ideas in mind at that moment, and so those ideas led to the C, which is the consequences. The consequences, whether how do I feel and how do I behave. So the ABC model is a very simple way of analyzing the consequences in the form of the emotions I feel and the behavior I do in terms of those thoughts came in mind. The ABC model is used in the form of a 3-column table sometimes for the functional analysis. But this model, though it's very simple, but it gives a very good and substantial way to find a solution, because according to this model, it's not the situation that caused our distress, it's the way we think about it. So it's not the person who is irritating me, it's the way I'm thinking about the person that irritates me. So it gives a margin of maneuvers, because I cannot change the situation, but I can change the way I'm seeing it. And this doesn't mean that I have to see the bad situations as being good, but I have to see the bad situations as being bad situations. Like, for instance, the last slide. I will take the last slide of my colleague when she said that the patient is telling, I can't stand it. I can't stand it means that she is confusing needs and wants. I can't stand something means that I need it. In fact, I don't need anything apart from things that keeps me alive. I need air, I need to eat, I need to sleep. Anything else is not a need, it's a want. So if I say that, I can't stand that my daughter is not, or my sister is not phoning me for the last week. In fact, I would rather prefer if my sister was calling me this last week. So in fact, it's not a matter of simply rephrasing. Well, I'm just taking an example of how those automatic beliefs or those automatic ideas coming in mind are influencing the behavior and the emotions we have. In fact, how you say to yourself is how you are going to feel. The way you are saying things to yourself is influencing the way you are going to feel and how you are going to take a reaction. So I'm taking the example of the last slide by my colleague, and she gave the chain reaction of one borderline patient who said that her sister was not calling her for the last week, and then she felt alone and she called, I can't stand it. So if I say that, I can't stand it, what is the next solution if I can't stand it? I cannot stop it because I have no control. Because I can't stand it, then I will kill myself. So the way I'm telling myself that I cannot stand that my sister is angry or I don't know why she's not phoning me for the last week. But supposing that I rephrase that phrase, I only rephrased it. So what better describes the situation is not that I don't stand it, because I'm here anyhow. I'm physically here, so I can stand it. So what happens is that I would rather prefer that my sister phoned me last week. Do you think that if I'm telling myself that I prefer that my sister this last week has phoned me, would it initiate the same reaction as if I'm telling myself all the time, I can't stand that she is not phoning me all the time? This is an example of how automatic thoughts are pushing someone to a certain reaction, and how one can simply change his reaction by rethinking the situation differently. No, I can't stand it because I don't need her to phone me, but I like her to phone me. I prefer that she phones me. I like it very much that she phones me. But I will not die if she doesn't phone. All right? So the problem with the automatic thoughts is that they are not built by a cognitive elaboration. They are just coming spontaneously, and that's why they are called automatic thoughts. And so my idea is that the moral values and your conscience, the way you are judging what's right or wrong, what will be more fitting as a good behavior or reaction in this situation or the other situation, is playing a major role in judging our automatic beliefs, because our automatic beliefs are not coming, in fact, from hazardness. There is something that works in the baseline. There's something that works online. Maybe we are not aware of, but our conscience is one of those tools working online and giving orders of what's right or wrong. And to understand what is this conscience, if we simply define the conscience as the heart of your brain, as simply what judges you as being kind, nice, and good, and what judges you as being bad and not worthy. So I will trace back some theories trying to explain how the morality is developing with time. And one of those old theories is the three-level theory of Kohlberg. And Kohlberg described three stages for the moral conceptualization as a pre-conventional, conventional, and post-conventional, simply based on the inherent empathic capacity of the brain to feel how the others feel. So if a child feels that the mother is happy, then I'm a good child, automatically. If the child feels that the mother is angry, then I'm not a good child. So this is an inherent empathic capacity of the human being. So what happens, according to Kohlberg, is that simply the circle of reaction is getting widened with time. So when you are a child, your circle is restricted to the caregivers. But after a while, it gets to the society and the conventional stage. And then get to not only to my society, but to a more universally accepted values, like not to harm anyone, not to cause physical damage to anything. So the concept of morality is developing according to the circle of interaction. Then came Gilligan, and she described three stages. And these stages are very interesting because they share some points with the theory of conceptualization that I will discuss in the later slide. So according to Gilligan, the first stage is oriented towards individual survival. So the child is crying because he wants to eat. The mother gives him what he needs, and then he stops crying. So simply all what's being good or bad is simply articulating around survival, around just keeping alive. But after a while, the child starts to build the concept of being good or bad based on the reaction of the mother rather than his own needs. So what the mother or the father judges to be right, this is right, and this is I'm a good child. If they judge that I'm bad, then I'm bad. So this is a stage where there is self-sacrifice. There's in fact self-effacement. I'm sacrificing my needs and putting the needs of others, I mean by others, the caregivers, the priority for my own needs. And then at stage 3, morality is based on universal concepts of nonviolence. So when I took a look on these morality concepts, and I tried to understand how the suicide can take place within a frame of understanding the morality evolution or morality development, I will find the following. Well, according to the psychoanalytic concept, whenever someone is pathological, he is regressing back to an earlier stage of development. So he is adopting a more primitive way, a more primitive defensive mechanism that are used in an earlier stage in the psychosocial developmental theory of Freud. All other analytical theories, the new Freudians, are adopting the same concept. The same applies to the cognitive behavioral model. So if I'm facing a situation that's very distressful, I'm very stressed, I will adopt a more primitive way of thinking that sometimes is illogic and irrational. The more I'm developed, I should be rational. The more I'm getting more primitive, I will get irrational. So the fact that I'm adopting a cognitive error or automatic thoughts that are not rational, are not logic somehow, this means that I'm regressing back to an earlier stage. But if I'm going to apply the concept of moral levels that have been explained by Jelligan or Kohlberg, then if I'm going to face a difficult situation, I have to regress back. And if I'm going to regress back, I have to be more self-protecting. So the frame of the morality concept doesn't fit the normal or the usually accepted concept of regression back that is used in almost all psychotherapeutic modalities. Because simply if I'm going to regress back, I will protect myself more. So another theory I came across just by chance, and it's not a new theory. It has been built up in '82 by Professor Barbara Stilwell and Professor Matthew Galvin. Both are in Indianapolis, and they are still working. And I found that this model is very interesting in the way it tackles the conscience issues, how it analyzes the conscience in a more deeper way. And then I will expose some of the exercises used and how it resolves certain problems, technical problems or technical difficulties that we may encounter with the classical CBT technique. This link, hyperlink, is where Professor Stilwell has put all the data, all scales, all interviews, and all published articles related to those topics over the last 30 years. And it is free. It's free PDF. So, according to that model, they analyze the moral system on 5 levels. The moralization of attachment, emotional moral response, moral valuation, and moral volition, and then a whole meaning or an overall moral meaning of anything. What does that mean, in fact? Well, she was trying to analyze the morality as a concept, but with 5 components. Let's say like that, 5 components. When the child first starts his reactions with the caregivers, the father and the mother, he has that inherent empathic capacity. So he can understand that the caregivers are satisfied or they are not satisfied. The child himself has his own needs. Some of them are met, some of them are unmet. And the caregivers have their expectation from that child. Some of them are met, and some of them are unmet. So, the child articulates his moral concepts around trying to have his needs met and satisfying the parents as far as he can, in what's called the secured attachment bond. The same way the Bowlby is talking about the secured attachment. But when he grows more, he implicates another component, which is the emotions. So it's not only about doing that because this is right and wrong according to the caregivers, but I'm good according to the parents, so I feel good. So there's another dimension that develops. So I feel good when I'm considered good by parents. I feel bad when I'm considered bad according to my caregivers. And then as the child grows up more, he develops a more information processing capacity. So the child not only tries to feel good, but he tries to analyze to what extent his needs are met and to what extent the expectation made by the parents do suit him. So he tries to analyze whether I have needs and others have needs. And this makes more emphasis on the patient because it makes what Professor Stilwell is calling the crisis triangle, by which I'm making a relation with self, with peers, and with superiors. So I have a relation in the form of needs and expectation from others related to my relation with self, my relation with my colleagues and peers, and my relation with those superior to me, like whether my professors at the university, my professor at the school, my parents simply. And so after that there's the moral volition, which develops when the child develops his capacity for an autonomous behavior, just to take a behavior in an autonomous way. So it's the willpower of the conscience. So the needs for attachment creates a value for connectiveness, how I should be connected to others. The needs for emotional regulation create a value for harmony. And the needs for logic, structured way of thinking creates a value sensitive skills. Need to react or restrain creates a value for autonomous will. And those four components create together what we call the moral meaning. So Stilwell proposed an interview that she passed with adolescents and children. And in that interview, she simply was starting to check how persons are perceiving the conscience according to their age group, how they are perceiving their own conscience, how do they say it. And she recruited children, I think starting from 6 years, and she recruited children who had no psychopathology and had no significant trauma and having no learning disabilities. And there was no assumption made before passing the interview, and the interview was or had a good construct validity and good reliability. And then she described those stages of development of morality, which is, in my opinion, much deeper and more explanatory than the previous models. She described the external stage. The external stage means that children at that age group see the conscience in the form of different scenarios where I will get punishment or gratification. Just different scenarios. I will make this action, I will be gratified for. I will make this action, I will be punished for. And then the brain-heart stage from 7 to 11, where the conscience is simply seen as a reservoir where moral values are being stocked. The personified stage, which is 12 and 13, where children at that age group see the conscience as a person inside making an internal dialogue, judging or making a moral judgment of how do they behave and what did they say. And when they grow in the adolescence, starting adolescence, they get the confused stage where they see the conscience as the area where one is trying to integrate different moral values from different systems. So I'm trying to integrate the moral values, and that's why there is a lot of confusion and sometimes identity crisis, turmoil during the adolescence, because what's right or wrong is not that of the parents anymore. I have the parents, I have the society, I have celebrities, I have singers, I have this. So I'm trying to integrate the morality or the moral system, but from different systems. So I get confused. And the last thing is the integrating stage from 16 and above, where the adolescent get aware that the conscience is a separated entity where there is goodness and badness, and I can integrate goodness inside evil or goodness inside badness and badness inside goodness. So it seems that regressing back to an earlier stage, which is used for analysis and CBT, and does not apply for the morality, but what really applies is that it is demoralized. So when someone is committing suicide, he is demoralizing the question. He is putting his moral system apart, so it's not to judge right or wrong. So the question is how to remoralize back again through life-affirming values. And here is one of the exercises the conscience-sensitive approach are proposing. We have the suicide walk. In the suicide walk, you ask the patient to describe what will happen after his death. I mean, I will suppose that you committed suicide, and what I want you to do is to make a story or to try to describe what happens. What happened in the funeral? Who is crying? Who is sad? Who is happy? Who was there? What happened to your family after? How do you imagine your children after? It's a very difficult exercise, but it is appreciated by adolescents. Particularly adolescents do like it. And the aim of that exercise is really to mobilize the emotions of the emotional component of the conscience back again. I have emotions, emotional power of the conscience related to how do I feel in relation to my reaction to others. So I'm trying to stimulate, or this test is trying to stimulate this emotional component of the conscience back again. So how do I feel in relation to the others after the whole story is ended? I will get to the exercise 4 and return back to 3. This is a magnificent way, a magnificent and very nice and easy technique to do, which is breaking the motivational power. Well, when you ask a patient, why did you commit suicide? He will tell you, well, I committed suicide because I cannot stand my mother. My mother is very bad with me. All right. Supposing that there is a miracle and your mother is becoming very nice to you, what else will push you to commit suicide? If the patient finds a second reason, then we will say, supposing that this second session, I know it's hard, but supposing that it has been resolved, what else? So you go through what else, what else, what else. This is really activating the cognitive power of the conscience, the valuation, the moral valuation. So I'm trying to bring the moral valuation back again to a healthy track. Because when you are talking to a very distressed patient who committed suicide, he is so depressed enough not to see any positive aspects. So if I'm telling him that you have to make a two-sided arguments, what's with and what's against, usually he doesn't find something to keep him alive. But if I'm telling him, I'm pacing him down by saying, supposing that this solution has been resolved, what else will push you to commit suicide? So it's an open-ended question that really activates the way of thinking of the patient so that he is searching another reason. And if he's searching another reason, he is searching and he's fine, that's good, no, that's good, this good, this good, this good. So he's searching, he's making a screening, he's searching for another reasons to commit suicide and he cannot find. And you can shift it to the opposite. I mean, if the patient doesn't find any, you can ask him, so in your opinion, what, apart from the difficult situation you talked about, what's in your life can keep you alive or can keep your life happy? I will say that, say what else, and what else, and what else, and what else. This is enriching for the life-affirming values. I think the time is ending, so I will return back to the exercise 3, which is a value matrix.
Actually, the dinner has started. So for
Ah.
this, a lot of people have been now to the dinner.
Yeah. Yeah, it's 5 minutes and we
Stomach
will.
is
Yeah.
sometimes.
Yeah. So this four square organizational value, it's called the value matrix. And in the value matrix, it's made after the breaking the motivational power of because, and then to do the act and not to do the act. I mean, to commit suicide and not to commit suicide. What are the reasons you find it most appreciable to commit suicide? And what is the true motive? The true motive is different from the reason. If I'm saying that I commit suicide because, for instance, the last slide of my colleague, the reasons that my sister did not show up or did not call me for the last week, and what is the motive? The motive is that I cannot feel alone. I need to have strong relations with others, stable relations with others. So I have a motive and I have a reasons. And before going to these four corners or four blocks table, it's better to bring the chain of reaction by blocking the motivational power of the word because. Because as you say because, I'm giving another motive. And I'm saying more because, so I have another motive. So this model is simply the levels of intervention when you are facing someone with suicidal thoughts. So we have a stress that activates suicidal thoughts, and suicidal thoughts will come to a suicidal urge. So there's an imminent risk to commit suicide, and then ultimately the suicidal attempt. So for the stress, you have to arrange for stress coping skills, and this is what happens in the DBT with the stress coping group therapy. And the suicidal ideations need a lot of life-affirming values, and suicidal urges need some suicidal risk strategies like the phone calls. And the emergency, a suicidal attempt, he has to get to the emergency department to be in a secured place. And this is classified, or this is summarize the idea that I want to communicate. The CBT, or the classical CBT, the DBT is adopting the same model of CBT, but the therapeutic frame is different. The CBT is built on the referenting technique. Referenting techniques is as simply as that. I want to kill myself, but in fact, I don't want to kill myself. I want to resolve a problem somehow. So let's discuss other options so that we can resolve the problem other than killing oneself. And then try to compare the different methods in terms of advantage and disadvantage. So it returns to the famous two-sided argument table. What one finds in practice is that this two-sided argument table sometimes is not that practical because patient doesn't find enough data to put in the positive angle. So what really happens with the conscience-sensitive techniques that I find magnificent is like the breaking the motivational power rather than asking what's with and what's against. Let the patient with an open-ended question just search for what's positive in his life rather than putting that in a table.
And if the person cannot find
No, it's difficult. When you ask it like that, it's very difficult to find that the patient has no answer. If you say, all right, if the patient says, well, I commit suicide, I cannot stand my father, he has been abusing me all the time. All right, supposing that your father, for a miraculous reason, for a miracle, he is becoming very gentle and very nice to you. What else will push you to commit suicide? So I'm supposing that for a miracle, the situation has been resolved. What else? And I'm proposing, if he finds another reason, I will say, suppose that this reason has been resolved. What else? The patient will stop at the second or the third else, because he finds nothing else. But he finds nothing else, but he is trying to search. In fact, he doesn't reply directly. He's trying to search. But this open-ended question, in my opinion, is very advantageous in comparison to the classical two-sided arguments that we are utilizing in a CBT. Because if I'm asking what is with and what's against, he will complete the column that's against to keep him alive, and he will find nothing to keep him alive, at least in the acute stage. But when I'm pacing his anxiety down by asking, supposing that the situation has been resolved, so I'm pacing him down, and what else? So this is the way I'm finding that it can resolve the problem, like the breaking the motivational power, and through breaking the motivational power, we can discuss in a deeper way that your true reason for to commit suicide is not to kill yourself, but there is another motive for that. That's what we bring through the breaking the motivational power. And the suicide walk is a great tool, particularly among adolescents, just to activate the emotional component of the conscience and to break down the suicidal thoughts. Well, I will stop here. I hope that the things are clear. Thank you very much.